Good morning. So this lecture is going to be on the end part of the PowerPoint for chapter 34, lower GI, and it focuses just on ostomies, okay? So it actually starts on slide 65 in the chapter 34 PowerPoint. So ostomy management. What is an ostomy? An ostomy is a surgically created hole or opening that will divert or change the route of stool or urine to outside the body. Okay, and the stoma, so the thing that you're looking at, is actually a portion of the bowel that gets sutured onto the abdomen. So that stoma is part of the patient's intestines. So the different types of ostomies, we have ileostomies, colostomies, and urostomies. So when you hear ileostomy, that's in the ileum, remember the distal portion of the small bowel. Colostomy, the colon, which is the large intestine. And then urostomy has to do with the diversion of urine. So we'll talk about that in a moment. Okay, so the terminal ileum, okay, which is the end portion of the ileum, the distal portion of the small bowel, is sutured to the abdominal wall after a total colectomy. So in other words, let's say the patient had either colon cancer or they had Crohn's disease or ulcerative colitis, rarely, but more so often Crohn's disease or cancer are the two main causes that have basically eroded away the colon, the large bowel, and it's had to be removed. And so there's no large intestine. So what we have is the end of the small intestine, the ileum, has now an ostomy, or that small intestine, that ileum is now the stoma, where the fecal matter will be expelled through the body. You will usually see a smaller stoma with an ileostomy, and it's usually at the right lower quad. And here's the thing, the effluent, which is another word for the feces, but it's not really feces yet because there's no large intestine. So what you have is a continuous flow of liquid, and there's no odor. And the color is usually more of a greenish, more so than a brown color, because the color and the formation of stool happens in the large intestine, and there isn't any large intestine. Okay, these are harder to manage because of the fact that the effluent is liquid, and so they're flowing constantly. They really have to be watched, or the patient can wind up having an accident where it blows. In other words, the appliance that's on there will actually be overflowing, and that's a problem. Then there's something called a continent ileostomy, or a coke pouch, which is an internal reservoir that has to be emptied about 3 or 4 times a day. There's also an ilioanal or iliorectal anastomosis. We'll get to these one at a time. So when we hear the word anastomosis, that means connecting two ends of something together. That's an anastomosis. If you take a look at the next slide, number 67, you can see some diagrams that kind of represent the continent ileostomy. So you can see in figure A that they've got that part of the ileum that is actually sutured together. And what they do is they divert it and they create the stoma through the abdominal wall. Okay? All right. Slide 68 gives you an idea of what an ilioanal anastomosis, or a J pouch, looks like. And what they've done is they've created a diversion. There's a pouch here. You can't see it. So there's a pouch there at the blue area. Don't worry too much about the ilioanal anastomosis, but here's what you really need to focus on: the different types of stomas. Now, this is really important because the board and ATI like to ask about ostomies and ostomy care. So, you know, what you're teaching the patient. There's a lot of teaching involved. Just so you know, with ostomies, there is something called a WOCN. It's a wound and ostomy care nurse. Special certification that nurses that are interested in wounds and stomas can get, that kind of make them a specialist, if you will, in these types of things. And usually when a patient has to have an ostomy done, the hospital will have that WOCN go in and counsel the patient, teach them about the appliance, about the care, and all those things. So it's important for you to know the types of stomas and what they look like so that when you're assessing your patient, you also understand how to educate them. Slide 69 goes into detail with some diagrams to show you where there's a resection done. Where, in other words, so they've taken out the distal part of the colon and resected it to make an ostomy. And you can see where the proximal end of the stoma is what actually is bulging out of the person. And with stomas and with colostomies too, by the way, you want to make sure that the stoma should be a pink or red color. It should look nice and healthy. It should never be grayish in color. That would indicate that there's some kind of a compromise in blood flow to it. Now, heaven forbid it looks black. That's necrosis. That would be bad. And just like when you're assessing a patient's bowel sounds to see if they have peristalsis, it's the same thing here. They're going to have gas come from the stoma, flatulence. And that would be a sign that the bowels are functioning. There's peristalsis in addition to listening to the bowel sounds. And that's important for you to remember. And also, when we're talking about a colostomy, you've got the ascending colon, the transverse colon, and then the descending colon, which goes down to the rectum and the uranus. Anyway, understand that the location of the ostomy, okay, will dictate what the effluent looks like when it comes out. The farther down the line the stoma is, in other words, the more distal it is, closer to the rectum, it's going to be more solid, like a regular bowel movement. The higher up it is, in other words, up at the ascending or the transverse colon, transverse, it's going to be a little less solid. Ascending, it's going to be even less solid, more liquid. And then you get to the ileostomy, which is just liquid, okay? And also when it comes to odor, the further down the line it is, the more distal the stoma is, the odor is more aromatic, if you will. An ileostomy typically does not have odor, hasn't had the opportunity to smell because it's just going through the small bowel. There is no large bowel, okay? Okay, you want to make sure that you understand about how to care for appliances. A couple things to know, and these are very important facts. Number one, when it comes to caring for ostomies, it takes a skilled licensed nurse to perform an appliance change. When I say appliance, when I say wafer, those things are the actual sticky, flesh-colored thing with the hole in the middle that sits on the patient's abdomen around the stoma. And then there's a bag that is, or a pouch it's called, that attaches to that appliance or wafer. An aide can change the bag, can empty the bag, can burp the bag. And you would burp the bag to, get gas out of it so that it doesn't explode. But an aide cannot change the appliance, the wafer, because doing that requires what I say all the time, right? You can't delegate whatever you can eat, evaluate, assess, or treat. When you change the wafer, when you take that appliance off of the patient, you need a skilled professional to observe the stoma and the peristomal skin to make sure there's no maceration or breakdown of the skin. So, especially with ileostomies, you got liquid stool that's constantly flowing. And if there's any kind of a leak in the seal around the stoma, that's acidic. And what that will do is it will literally eat away at the peristomal skin. And once that happens, then it's even harder to get a seal. And then there's more leakage. So you see how that can become kind of a vicious circle for the patient, where they are going to have a very difficult time maintaining the integrity of the seal of the appliance. Okay? So aides can change the bag, empty the bag, burp the bag. Aides cannot change the appliance or the wafer. Okay, make sure you know that. When you are cutting a wafer, because the way the appliances come, they will have, in a package, the wafer, and then there is a template, okay? So each patient is different. Each patient's stoma is different. So there will be a measurement with a template telling you what size the opening needs to be so that it fits around the stoma. The wafer should never fit right up against the stoma. If it does, it could cut off the circulation to the stoma. So the rule of thumb usually is you want at least an eighth of an inch, right, around the stoma so that the stoma has room to breathe. The stoma will kind of move a little bit in and out. Think about when you laugh, when you talk, when you breathe, when you cough, when you sneeze. Take your hand and put it on your abdomen. Even while you're talking, you can feel your abdomen moving a little bit because of the musculature and the flow of air in and out. Same thing with a stoma, right? So that you're going to see when you're assessing the stoma, sometimes it'll kind of move in and out a little bit if the patient's talking. That's okay. If you look at the stoma and it's suddenly protruding 2 or 3 inches outside the body, that's the problem. Or if it is prolapsed inside where it's inverted, in other words, like an innie belly button, that's also could be a sign of a problem. So that's something that needs to be reported to the physician. Okay. All right. Let's see. What else do I want to talk about with this? There's some nursing diagnoses here as far as the appliance changing and daily care, hygiene, et cetera, et cetera. Body image disturbance when it comes to ostomies is really a big deal for people. It really is. For people that have a permanent ostomy, in other words, this is something that they're going to have to live with for the rest of their life, it really, really can do something, especially if they're a little younger. I mean, it doesn't even really matter. I shouldn't say that, but it's a body image disturbance. And so you have to really be supportive in helping that patient, number one, look at it. That's a big deal for some people. Whenever there's body image disturbance, the patient's ability to look at the site where the disturbance emanates from, women that have had mastectomies will typically have a very difficult time just looking in the mirror at the surgical site. People that have had ostomies sometimes will, have a difficult time just looking at the ostomy, and they'll be saying things like, oh God, this is horrific. I don't want to look at it. Nobody's ever going to love me again. I'm disgusting. A variety of things. So you have to really exercise therapeutic communication when you're dealing with these patients. It's difficult. Now, keep in mind, sometimes an ostomy is temporary. So let's say that we've done a colonoscopy on a patient and we found something questionable that we believe may be the beginning of colorectal cancer, and it's somewhere at, say, the descending colon. Well, the surgeon can go in, remove the affected portion of the colon, and then create the stoma. About 6 months later, once that all heals up, surgeon can go back in and reverse it. In other words, push that stoma back in and do an anastomosis to connect the ends of the intestine, the descending colon, back together without that infected piece, once that infected piece has been removed. So temporary, still a body image disturbance. Permanent, definitely a body image disturbance. A couple tricks of the trade when it comes to odor. There are deodorants, and don't confuse this. I don't mean deodorant like you use under your arms, okay? Deodorants, they're called deodorants, but they are deodorizers. Deodorant, removal of odor. Because ostomies, especially colonostomies, can smell, and that's embarrassing for people. So there are these products that are deodorants. They're little drops that they can be placed into a fresh bag that kind of neutralize the odor of the stool, help with that. Never, never, never put an aspirin into the bag. This is some kind of an old wives' tale that has been perpetuated. That is a no-no. It will macerate the stoma and the skin around it. Aspirin is acetyl salicylic acid, right? So you wouldn't do that. There is a trick about putting a tiny breath mint into the bag, like a Tic Tac. And believe it or not, you can do that, okay? But you're always better off using the product that is specified for the ostomy to remove the odor and neutralize the odor, okay? I think I've covered pretty much what you need to know. And that's about it for ostomies. So see you next time. All right. Bye-bye, guys.